Hi, my name's April Brownell, and I'll be presenting with my colleague, Jaden Allen. We're going to talk about our systematic review on hemodynamic differences between dexmedetomidine and fentanyl for awake fiberoptic intubation. As anesthesia providers, awake fiberoptic is a skill we don't encounter very often, but in cases of difficult airway, it's an important skill we need to be familiar with, along with best sedation techniques to keep our patients safe, breathing, and as comfortable as they can be in that situation. So to begin with, we know that awake fiberoptic intubation is the gold standard for managing patients with suspected difficult airways. It allows for spontaneous ventilation to reduce the risk of hypoxia, brain damage, and death. The Difficult Airways Society has developed guidelines for this procedure, and they currently recommend remifentanil with or without midazolam as an adjunct. However, they also support the use of dexmedetomidine with grade A evidence as a single-agent sedative for awake fiberoptic intubation. Dexmedetomidine has many desirable characteristics for use during this procedure, such as sedation, analgesia, anxiolysis, and sympatholytic effects with minimal respiratory depression. Dexmedetomidine is well known for its respiratory protection, but it's less known how its hemodynamic stability compares to other sedatives for this procedure. There was a meta-analysis performed comparing remifentanil and dexmedetomidine that showed there were similar effects on hemodynamics between the two drugs. But to date, there has not been a systematic review comparing this between dexmedetomidine and fentanyl, another commonly used opioid for awake fiberoptic intubation. We use the Rosworm and Larrabee model as a framework for our research. This model was created by Mary Ann Rosworm and Janet H. Larrabee to guide medical professionals through the process of developing and implementing an evidence-based practice change by incorporating 6 key processes. These processes are assessing the need for change, linking interventions to outcomes, synthesizing the best evidence, designing a practice change, implementing and evaluating, and finally, integrating and maintaining the change. In the context of our research question, this model can be systematically implemented and evaluated to compare dexmedetomidine and fentanyl as sedatives for awake fiberoptic intubation. So our problem statement was the hemodynamic stability of dexmedetomidine compared to other commonly used sedatives for awake fiberoptic intubation remains unclear. This systematic review aims to determine how dexmedetomidine compares to fentanyl as evidenced by blood pressure and heart rate changes during awake fiberoptic intubation. Our criteria for studies included in our review were randomized controlled trials. Participants were 18 years of age and older, undergoing awake fiberoptic intubation. Interventions included IV dexmedetomidine compared to IV fentanyl, and a primary or secondary outcome measure included blood pressure and heart rate changes. This image is our PICO search strategy chart, which shows our search strategy terms for our population, intervention, comparison, and outcome. We use these terms using academic databases including Medline, Cochrane Central Register of Controlled Trials, Accumulated Index in Nursing and Allied Health Literature, Embase, ProQuest, Ovid, and ScienceDirect. We also searched Google Scholar and did citation searching of relevant articles to be as exhaustive as we could in our systematic review. This image is our Prisma diagram, which shows our literature selection process. Our literature review yielded 28 articles from academic databases and 21 articles from both Google Scholar and citation searching. We assessed each article to determine if they fit our inclusion and exclusion criteria and excluded 34 of the articles. The remaining 15 articles were screened for eligibility by review of the full text of the articles, and they were appraised using the Joanna Briggs Institute's checklist for randomized controlled trials. We excluded 10 of the articles for reasons listed in the diagram, and 5 articles were included in the review.
By analyzing each study's results and identifying patterns and trends in the data, we determined consistent findings related to whether patients were fluid-loaded prior to induction. We initially identified themes such as difficult airway studies, studies involving preoperative midazolam, and those with similar ASA ranges as likely to produce comparable outcomes. However, further analysis revealed inconsistent trends within these themes. In the study, Rajan et al., patients with anticipated difficult airways undergoing head and neck surgery and classified as ASA physical status 1 to 3 received a 500 ml crystalloid infusion. Although the study initially hypothesized that dexmedetomidine would more effectively attenuate the stress response than fentanyl, the results showed comparable hemodynamic parameters for both drugs. In the study, Yadav et al., patients with anticipated difficult airways undergoing awake fiberoptic intubation, classified as ASA scores 1 and 2, received 5 to 10 ml per kg per hour of crystalloid fluid. The results demonstrated that both drugs were similarly effective in providing moderate sedation for awake fiberoptic intubation. While dexmedetomidine showed slightly better hemodynamic stability and lower desaturation rates compared to fentanyl, both studies concluded that the two drugs are comparable when combined with IV fluids. The studies that did not fluid load clearly demonstrated that dexmedetomidine provided superior hemodynamic stability than fentanyl during awake fiberoptic intubation. The Elmdarash et al. Study included difficult airway patients undergoing awake fiberoptic intubation for elective abdominal or maxillofacial surgeries. In the fentanyl group, post-intubation MAP and heart rate significantly increased, while the dexmedetomidine group showed a significantly decrease in post-intubation heart rate. The Mendal et al. Study included ASA scores 1 and 2 undergoing awake fiberoptic nasal intubation for elective laparotomy surgery and excluded difficult airway patients. This study demonstrated post-intubation MAP and heart rate rose significantly in the fentanyl group, whereas the dexmedetomidine group experienced a notable drop in heart rate. Panwar et al. Utilized lower doses of study medications and excluded patients with difficult airways, observing significantly higher heart rate in the fentanyl group after bronchoscopy, intubation, and 2 minutes post-intubation. Additionally, MAP was significantly higher in the fentanyl group immediately following intubation. The findings suggest that fluid loading plays a key role in enhancing hemodynamic stability, particularly when paired with dexmedetomidine. The data highlights the importance of carefully considering patient preparation and treatment protocols, as such details can significantly influence outcomes. It also reinforces dexmedetomidine's potential advantages in providing more stable cardiovascular conditions during procedures. The idea to fluid load patients and the resulting improvement in hemodynamic stability really highlights why every detail in research matters and needs to be carefully considered. This systematic review included high-quality, prospective, double-blinded, peer-reviewed RCTs with consistent methodologies primarily conducted in India, except for Elmdarash et al. In Egypt. Demographics were comparable within studies, minimizing bias through controlled medication administration and robust statistical analysis. However, generalizability was limited as most studies focused on ASA 1 to 2 patients aged 20 to 40 with small sample sizes. Panwar et al. Further complicated interpretation by testing varied drug dosages and including a rescue adjunct, making it difficult to isolate hemodynamic outcomes for specific agents. Overall, limited scope and methodology variability may impact the broader applicability of findings. Studies without fluid loading showed greater hemodynamic variation and more significant differences in outcomes between drugs. Dexmedetomidine also exhibited less desaturation and respiratory depression, better sedation, endurance, intubation conditions, and overall greater patient satisfaction. This review supports dexmedetomidine for awake fiberoptic intubation, highlighting its patient satisfaction and minimal risks. The variability in clinical sedation techniques emphasizes the need for standardized guidelines, including dosing protocols for dexmedetomidine to enhance safety and consistency. Further research is required to refine dosing with adjunct sedatives and address potential side effects despite modern confidence in its superiority. Future studies are crucial for establishing standardized dexmedetomidine guidelines in awake fiberoptic intubation. They should include larger samples, multi-center trials, broader ASA scores, and diverse geographic representation while also including patients with anticipated difficult airways is essential, as awake fiberoptic intubation is the gold standard for their management. Thanks for listening. I hope you enjoyed our DNP project.